Hello, my name is Jamie Scalise. I'm in the mammography program at College of DuPage. Today I'm going to speak to you about a breast disease, invasive ductal carcinoma. So, what is invasive ductal carcinoma? Invasive ductal carcinoma is a cancer that begins in the cellular lining of a milk duct in the breast. That cancer penetrates the membrane of the duct, spreading into the surrounding tissue. And in more advanced cases, the cancer can spread or metastasize to other areas of the body by way of the lymphatic system or bloodstream. We can find this by way of screening mammography or by clinical or self-breast exams. Now, if we look at the breast here, we can see the milk sacs. These are called lobules, and they carry the milk down through the ducts towards the nipple. Look, here is a milk duct with no abnormal cells inside. This milk duct has abnormal cells, but they remain inside the duct. Now, a milk duct with invasive breast cancer, you see these abnormal cells, they break through the basement membrane. What happens then is it can metastasize to other areas of the body. So we can see in this image here, the primary cancer, these cancerous cells find their way into the bloodstream and through the lymph nodes and can travel to other areas of the body as seen here. Another anatomy picture here, you can see the fatty tissue of the breast and the ducts here, and this is just another cross-section of the duct where you can see abnormal cells breaking through the duct wall. Now, who's affected by invasive ductal carcinoma? According to the ACS, over 276,000 women will be diagnosed with invasive breast cancer in 2020. 8 in 10 of those will be IDC, invasive ductal carcinoma. In men, about 2,600 new cases of invasive breast cancer will be diagnosed. So there's some risk factors that we can't control. Number one, being female and then getting older. Inheriting some gene mutations, such as the BRCA1 and BRCA2 gene. Family history of breast cancer, it's usually increased with a first-degree relative having breast cancer, and your own personal history of breast cancer increases your risk of having another one. Race and ethnicity play a role, and having breast dense tissue is also a risk factor we cannot control. Now, if you look at this graph here, this is a graph about race. You can see the incidence is a little higher or much higher for non-Hispanic white women, followed closely by non-Hispanic black women. The other three races remain about equal. The darker pink bars are mortality. So unfortunately, you can see non-Hispanic black women actually have a higher mortality when compared to non-Hispanic white women, even though they have a higher incidence. So there's some other risk factors here. And these are ones we can control. These are lifestyle risk factors. So, drinking alcohol, not having children, or having your first child after the age of 30, and not breastfeeding, or being obese or not physically active can actually increase your risk. Taking birth control pills or hormone replacement therapy also has been shown to increase a woman's chance of getting breast cancer, but they don't fully understand why that is yet. Now, 75% of women diagnosed with breast cancer do not have any risk factors whatsoever. So that's why it's important to go for your screening mammogram, your annual mammogram. It remains the single best method of detecting breast cancer because it can see a breast cancer before it can be felt by doing a self-breast exam or a clinical breast exam. Now we're going to look at a case study here. This is your annual screening mammogram. We have a right CC or craniocaudal view and left CC view. This is the right breast in a medial lateral oblique projection and the left breast with the same. So when we see tissue on a mammogram, there's fatty tissue, and then there's glandular and dense tissue. That shows up as white on a mammogram. So sometimes we see dense tissue, and it is a tumor. So in this case study, this 57-year-old woman was found to have a 1 centimeter mass in her left breast in the upper outer quadrant. You can see it here. And we also see that there's a mass in the left axilla, that is, in the armpit. This is likely an enlarged lymph node. So there's further workup that's done. In addition to mammography, we also use ultrasound to help determine what kind of mass this is. You can see an ultrasound picture from this particular case. This shows that that mass that was seen is actually dense and solid, and it's not fluid-like, which means it's probably not just a benign cyst. This is also the mass in the axilla, or the armpit, showing an abnormal lymph node. The diagnosis on this patient, after a needle core biopsy under ultrasound, or they take a sampling of that suspicious tissue and they send it to pathology, is unfortunately that this woman has a grade 2 invasive ductal carcinoma and also metastatic breast carcinoma in the lymph node tissue, which means that cancer that was in the left breast had spread into the lymph node tissue. So now we want to look at the prognosis. So once the tissue from that biopsied mass is sent to pathology, we can gather more information about how the cancer will behave and which treatments would be most effective. So that tissue is examined and they want to see how the abnormal cells behave. And so they're grading that tissue, low grade, moderate grade, high grade, grade 1, grade 2, grade 3. We saw from that case study that it was a grade 2, moderate grade. They also look at when they actually remove that tissue, they want to remove the entire tumor with a little extra margin. That's called a clean margin. They want normal tissue around the cancer so that they're sure that there's no other cancer outside of the tumor. They got all of the cancer when they removed it. They also do some tissue tests for hormone receptors and gene receptors. And then they also stage the cancer. So you have stage 0 all the way up to stage 4, stage 4 being the worst, metastatic breast cancer, and it's spread to other parts of the body. Stage 0 is non-invasive and it's limited inside of the milk duct. For invasive ductal carcinoma, it would not be a stage 0. It would, at minimum, be a stage 1. And likely in that case study, with as large as that lymph node was, it would probably be greater than a stage 1 as well. From all that staging, then they can decide which treatment is best. They talk to the patient based on all the information gathered from the above information, and they see what's needed. Some are local treatments alone, and then they also are used in conjunction with systemic treatments. Sometimes those systemic treatments are used before surgery or after, or both, sometimes before and after. So local treatments would be surgery, like just a lumpectomy, just to remove that tumor with the clean margins, or sometimes a complete mastectomy where the entire breast is removed. Local treatments can also include radiation therapy, where radiation is just focused to the breast or lymph nodes to destroy those cancer cells directly. Systemic treatments are drugs that go through the body and can reach cancer cells anywhere in the body. They use chemotherapy, hormone therapy, targeted therapy, and immunotherapy. Those drugs help restore the immune response against cancer cells. I hope you have enjoyed my presentation. I thank you so much.